Everybody able to unmute and talk?
I can unmute and talk.
Yay! All right, good. Because we would like participation. Today's going to be a lot more some of the theory. Then next month we will get into the practicality and a lot more of the actual activities. And so anybody that wants to, you don't have to. Nobody has to talk if they don't want to. But if you do and want to ask questions or want to add insight, we would love to have you. Okay. All right, well, welcome everybody. I'm sure there's 70-some people that signed up. Some of them are still working, unfortunately. Well, that's actually fortunate, you know, that means they have patience or they're not able to attend the session right now, but they'll try to attend it at a later time. So we've been going through the basics of vision therapy. So we talked about, first of all, we were back on ocular motor, and that's getting the cameras to align. Then we kind of jumped into some fusion, basic fusion, some red-green luster, and then we worked through a little bit more of the different types of fusion. And then last week we talked a little bit some of the tools of the trade for some greater fusion using the VTS4. But we kind of skipped over accommodation. So I want to come back and work on a little bit of accommodation. And can anybody that wants to jump in and give me what is your definition of accommodation? What do you tell people when you start working on the accommodative system? You can put it into chat, or you can unmute and just shout it out. Did I hear somebody there? There we go. There's a few more that are coming in, so I'm just giving them permission to talk also. Okay, well, I lost my chat bubble, so if you put it in the chat, I am unable to find it. There it is. Okay, the eye's ability to adapt. Okay, good. So when we think about how I present it, okay, especially if I'm speaking to a child, is ocular motor is getting the camera to the right spot, okay? Now we could talk about binocularity as pairing the cameras, but getting the cameras to the right spot. And then accommodation is getting the accommodation is to get the picture clear, okay? So it is the focusing aspect. And I never try to confuse terms. So when I want somebody to fixate on an object, I'll use fixation or look at something. If I want them to use their accommodation system, that is when I will use the term focusing, okay? And that is the ability to make things clear on that Z-axis, okay? So as we go through these different slides and as we go through some of the different activities, so we'll kind of discuss them. I really hate when people just read everything that is on a slide, but it is kind of hard to know what people are reading and then what people are listening to them. So technically, accommodation is the act of focusing the eyes to provide an image clear enough for interpretation, okay? So if we're gonna have fusion, the information that is going to the brain, first of all, it must be single. So we must have motor alignment to align the eyes so that we're making a single precept. But then that precept has to be clear enough that the brain can decide what it is and interpret what it is, okay? So the stimulus to accommodation may come from blur on the retina or perceived as awareness of a proximity of a target. Accommodation is said to be stimulated when looking at near objects and relaxed when looking at far objects. And it's kind of funny that once again, it seems like everything that has to do with accommodation, it's a little bit backwards. Because how many of us have ever said, hey, look at that way over there, and people are like way bugging out their eyes and they're like straining, trying to see far, far away. And they feel like if they just focus harder, if they just accommodate more, then they'll be able to see that which is farther away. But as we know, the farther away that we're looking, the farther away the object of regard is, the less accommodation it takes, and we have to relax that accommodation out to see objects that are far, and then we have to flex or accommodate and focus in to see those things that are close, okay? Now, when we think about the accommodation system, it's part of the identification system. So it's going to be part of that what is, or the Parvo cellular system, and we're going to cover that in just a few minutes. But it is to give us really idea of what we're looking at. Now, if a person has blurry vision, most of the time we think immediately that they're going to need glasses, that there's some sort of refractive error that is going on. And then if they don't have a refractive error, then maybe there's an eye disease, or maybe there's a cataract, or there's something that is causing this eye to not be able to make things clear due to those situations. Or it could be that they're not able to get foveal alignment, and we'll cover that in just a little bit too. But if there's no refractive error, the doctor's gone through, they've done all their tests, they've been able to see, they've done their refractions, and they've seen where that is lining up, and they don't see any lag in there, they don't see any accommodative error, and there's no presence of the disease, then we start to think that, okay, there must be some sort of dysfunction that is going on in this accommodative system. The little example that you see here, if you notice when it begins, that first vase or first glass is clear, and then as it goes, each one clears in turn until you finally get to 20 feet out and infinity, and then from then on, everything is clear out of that. So when I'm explaining this to a patient, is to get them to understand that when we're dealing with the X and Y axis, okay, that is dealing with ocular motor, correct? If we're dealing with the Z axis, then of course we have convergence and we have divergence. But accommodation is also on that Z axis, coming towards us or going away from us. And in accommodation, we can only clear one point of the Z axis as we go until we hit that 20 feet beyond an infinity. Then when you're looking out, then your eyes are totally relaxed. From past that, that is as far as you can relax your accommodation. But if we're within that 20 feet, then we are beginning to accommodate. And so therefore it is one place on that Z axis. And that's going to be important because when we get to other activities near for heart chart, when we get to other activities where we're using lenses, they need to understand that accommodation is about space. It's about where something is in space before we can decide what it is in space, and then therefore make it clear. So here's a little diagram, and I don't know if you can see my pointer or not, but if we think about 20 feet and beyond, and what makes this interesting to me is if you actually have them stand up, okay, and look out straight ahead, the way that the human body is built is our eyes should hit the ground, okay, as long as we don't have our chin up or we're not going into up gaze. Our natural gaze, because the angle of deflection of our head and where our eyes are positioned, we hit the ground somewhere around the 20-foot radius mark, okay? So that place out there, 20 feet out, that's about where we hit. So we're kind of created to have this buffer of 20 feet around us, and that's where we're going to relax our eyes. And you'll kind of notice that the relaxed one, the lens is nice and thin. There's no flexation that's going in that's making that lens go from that relaxed state to flex state. So it's nice and relaxed. Light can just pass through that from a far point and get all the way back to the retina. Now, inside of 20 feet, that is when accommodation has to take place. And we have to remember that it is exponential, okay? So the closer we get, it's not just 1 diopter, 2 diopter, 3 diopter, 4 diopter. No, it rapidly goes, and there's a lot of math into that, and we're not going to go through all that. I don't understand all of it myself, but to be aware that what somebody is accommodating at 10 feet, 5 feet, versus what they're accommodating at 40 centimeters, 20 centimeters, that it is a vast difference. So the closer they get, the more accommodation that's taking place, and it's taking place much more rapidly and a lot more of it. So we kind of have to think about that. So I want, as a therapist, begin to think of this. How many classrooms, how many houses, how many places are children now, especially where it seems like more and more kids are not going outside, more and more kids are not out playing, throwing balls, running through the trees, going through the woods and all those different things. Because we've become so inside of a society, how many rooms are actually greater than 20 feet or give a visual field of more than 20 feet? Because maybe a classroom is, 25 feet long, but where that child is usually sitting, most places don't have a 20-foot viewpoint, okay? So if we think about that, that means most of the time, from the time a child gets up, or a patient, if we want to go to everybody, from the time a patient gets up, gets ready, goes to school or goes to work, while they're in the car, yeah, they may have 20 feet that they could look out, but how many kids, when they're riding in the car or looking at a phone or doing something within the car, or even reading? So that's close work. And then when they get to school, everything is in close. And you can kind of see that we've created a society, and we've created some of these platforms to where it seems like what we do is more and more and more close work, more and more close work. And the point of this webinar is not to talk about the increase in myopia, but if you think about that, if we're always at a near point looking, okay, and we're always having to accommodate, then the brain begins to say, hey, this is, I'm working hard here. I'm having to do this over and over and over again, and from a very young age. And so therefore, our DNA, okay, begins to say, well, you know what we can do is, instead of having this eye be, just nice, spherical, nothing going on, we begin to go more myopic and more myopic and more myopic, so that we want things closer, we take things closer, it's easier to see at a near distance because we're not utilizing that far distance, okay? And then you'll have these kids that they'll go myopic, and then all of a sudden they're more myopic, and then they're more myopic because they're doing everything within this sphere, okay? Hopefully that makes sense. So looking at this picture on your screen, just understanding when I'm relaxed, the lens is thin, and I'm able to see far or clear things that are far. When it's close, I have to flex that lens, flex the muscles that make that lens, so that the lens fattens up, if we could call it that. That is going to slow the light down and shorten its duration to the fovea. Okay, so shorten how far it goes to that fovea. So we're going to be working with patients, ocular motor dysfunction, some sort of binocular dysfunction. Some of them are going to have an accommodation function, okay? When we think about these dysfunction with accommodation, the symptoms that they're going to talk about are usually fatigue with near work, because they're just working really hard. Their eye stress, pain with any near work, headaches with near work, anything that is added accommodation. And then in that added accommodation, when they go to look far, things are blurry, okay? And we'll talk about a little bit about why. So when they do sustained near work, so maybe they wake up in the morning and they look far away, nothing's blurry, everything's great. But after they've been in school for a couple hours and they've been looking at books, and then they look up and try to look at something across the room as far away as they can, everything's kind of blurry. They might also have some of the more stereotypical accommodative symptoms, such as the words blurring in and out of focus, or seeing the letters kind of swim on the page. Now, this is different than convergence insufficiency, where they see things begin to double, okay? So as I'm working with a patient and they're talking to me, if they talk about words doubling or things doubling, then I think of that as that's a binocular. That's an alignment of the cameras. Both cameras are showing a picture, but they're not fusible, okay? So that's doubling. If they say things are blurry, or it's coming in and out of focus, or it's blurry and it looks like it has the halo around it, then I know that they're having a problem with their accommodation issue. Well, the problem can't be fixed with regular glasses, or the doctor would have just done it. What we have found in our clinics is that occasionally just giving a low plus, maybe like a plus 50 or plus 75 as an add, is super beneficial to these ones that have accommodative dysfunction, because it just helps to relax the accommodation and it helps to move that image out just a little bit ways until I can teach them how to use their accommodation system correctly. This at least gives a little bit of a buffer and gives a little bit of just kind of a relaxation, that they're not having to work so hard, especially if they're still going to school and then coming to see you. As much as possible, we want to eliminate some of those symptoms, and by giving them that plus, it can eliminate some of those symptoms. So what are some of the dysfunctions that are associated with the accommodation system? The very first one is just accommodative insufficiency, okay? This is a difficulty with amplitude, okay? And so the way I talk about amplitude is that it is all about the range that they can get, okay? So if my camera's kind of, I'm gonna back up just a little bit. So if I went to the gym, okay, and I picked up a 5-pound dumbbell and I was able to curl that, and then I picked up a 10-pound, and then I picked up a 15-pound, and then a 20-pound, and then maybe a 30. No, I couldn't do a 30-pound. I'm just joking. But you know, whatever the ending weight that I could curl in, that is my amplitude. That's how much I can handle. So if we think about accommodation, when the doctor is testing them and they have them in the phoropter and they're looking at a target, and it may be a near target or maybe a far target, depending on what the doctor's using, they're going to start to click in minus or plus, and let's just say it's minus, and they'll put in a -1, and then a -2, and then a -3, maybe a -350, and they'll just keep going up until the person says it's blurry, and we call that first blur. And then the doctor will say, well, can you make it clear? And they say, oh yeah, well, I can make it clear. And so they'll click it, and then all of a sudden they'll say it's blurry. And they say, well, can you get it clear? Nope, I can't get it clear, okay? So that is that person's amplitude range, okay? So when we're looking at that, how much can they accommodate? Well, of course, it depends on, you know, how big the font is, how far the font is, where that is, but that accommodation range and how far it is from their eyes, okay? And so your doctor will have a decision on based on the age of the patient and what they were using, how much amplitude they feel like that patient should be able to have, okay? Then plus, how far can they relax? Now, plus is a little bit different, because remember, once you get past infinity, you can't relax anymore, okay? So if the target is, let's say it's at 40 centimeters, you may have somebody that may be able to relax to a +2, maybe a +250, but because of the math of it and how far that's moving out, that might be all the plus that you could put in them and then be able to relax far enough out and still make it clear. So as a therapist, keep in mind where that infinity point would be, or where that total relaxation of the accommodation system would be. Because if you're doing monocular flipper reading, you might be able to go to a -3 or -4. I personally don't. I stay between a -2 and a -250. That's about as far as I go. But some doctors or some places want to go to like a -3 or monocular -4. But on the plus side, you're going to be stuck because you can only relax out so much plus, okay? So that's the amplitude. Now the in-facility is the next one, accommodative in-facility. That's a difficulty in flexation, okay? And the flexibility, or the ability to change from near to far or from far to near. So let's say I could curl that 20 pounds, right? But could I take that 20 pounds in and then put it out and in and put it out and in? And where would that break down? Or would I need to have a lower amount of weight? So a lot of people that have like accommodative excess, they're going to have the difficulty where they can take in minus, but then it's very hard for them to relax that minus back out, okay? So you can put minus on it and they can clear it, but when you flip it over to the plus, all of a sudden they're like, clear, okay? So their flexibility is lacking, being able to jump back and forth. And so you're going to have to deal with this. Just because somebody has the amplitude of being able to go to a -3 +2, that's probably not where you're going to be able to start doing flexibility training, because that's their amplitude range. That's the max that they can do when that's all they're focusing on. You need to work on lowering that until they learn that flex, and then that relax until they can get that flexibility and they can do more and more and greater and greater. So these different dysfunctions lead to this last one, which is called accommodative excess or spasm. Anybody ever have a Charlie horse in the middle of the night? I know I have. And if you think about that muscle, it just tightens up and it just won't let go. Well, if you have somebody that has accommodative excess, okay, and they're flexing that in, and it's hard for them to let go, and you just keep doing it and keep doing it, pretty soon that muscle just locks, okay, and they have that spasm. This is one of the things that, as a therapist, sorry, my pager's going off, but it'll be fine. It's okay. It's a different station. The worst thing that I can give an accommodative dysfunctional person is this accommodative spasm, because it pretty much shuts down therapy. Nobody wants to try to do therapy when their eye is spasming and they can feel that. It also is a great trigger for migraine headaches, and for headaches, it can give nausea, dizziness, all these different things. And so I'm not sure in everybody's clinic, you have different protocols, you have different ways that you do this. In our clinic, we could actually see the doctor's notes and we could read the doctor's records. So I would go in before I would start with a patient, especially if in their diagnosis chart they had an accommodation dysfunction code in there, and I would read where their ranges were, because the last thing I wanted to do was work that too hard and cause that spasm. So you got to be very careful with that. It's important to understand that the specific pathology of the patient's difficulty with accommodation, and we refer to these in a general term, okay, but they can also just be poor binocular dysfunction with accommodation, okay? So maybe their accommodation and binocular systems are fighting each other, or accommodation is trying to do what binocular should do, or binocular is over converging in order to pull in accommodation. So all these things don't occur in a vacuum, right? You don't have just ocular motor issues, just binocular issues, or just accommodation issues. Usually it's a blending of these things, because all these systems work together and are a part of each other, okay? So while it's important to know how and why these two types of dysfunctions interact and relate to one another, it's equally important to remember not to conflate the two, okay? There's separate dysfunctions in relationship and not just many-headed dysfunctions, okay? So what I mean by that is when you're doing an accommodative activity, but maybe you've got it set up in a binocular way, okay? So you have a suppression check, but you're doing an accommodative activity. If they have a problem, you as the therapist have to determine, was it their binocular problem that caused them to have issue, or was it the accommodation problem, okay? And being able to work through those different things. So where do we start? How do we start on this road to give them a better accommodative system? In my opinion, accommodation is all about the feeling and tone, okay? As in all therapy activities, it's not the activity, but the action that is important. So the action that we're looking for in accommodation, okay, is these things. One is a recognition of the feeling of flex or relaxation of the muscles that control accommodation. And really, that control accommodation only. So not what controls accommodation and what would control vergences, okay? But what controls accommodation. And we work with lots of kids that have very poor muscle tone. We've talked about that, and with doing convergence and some other things. And so when you ask them, do they feel, what their eye feel like, and you're looking for them to say, well, it feels like it was flexed, it feels like it was tight. If they don't know what muscle flexation looks like or feels like, that might be a hard concept for them to get. So I'll take my fist and I'll have them make a fist. And okay, I want you to squeeze your hand as tight as you can until you can see your knuckles turn white. Just squeeze, squeeze, squeeze. And I'll say, now what does that feel like? Okay, now relax your hand. Okay, does that feel different? Okay, so flex your hand, and they flex it, and I go, now feel what that feels like? Yes, now open it up, relax it. Does it feel different? Just getting them to feel the difference between a flexed muscle and a relaxed muscle. So sometimes we need bigger muscles to teach little muscles what it feels like, okay? Then get them to recognize what caused the feeling of accommodation, or the feeling of flexing or relaxation. So a lot of times, if you just take a flipper or a lens and just put it over somebody's eye, the brain will automatically accommodate. It'll automatically focus, and they'll say, oh, it's clear. And if you say, well, how'd you do that? They're like, I don't know. Well, did it feel different? Did you do anything? So we need to have them recognize what they did, okay? So again, whenever you have neuromuscular confusion, okay, you then have to have neurocognition of what the brain did to cause the muscle to do what it did, okay? And then a cognitive understanding of how to innervate that muscle as necessary, okay? So how to cause accommodation and then how to relax accommodation. So these are the starting points. So as we start to now get into some activities and think about the activities, is getting them to the point where they consciously, cognitively know, I did A, B happened. If I do this, this happens. And so then they can repeat that and do that again. All right. I'm just going to check to make sure there's no more things. All right. Okay. Anybody wants to jump in and chime in, feel free to unmute and speak up. We're glad to hear from you. All right. So the first activity I want to talk about is just look hard, look soft, okay? And a lot of people will say, well, James, this isn't an accommodation activity. This is a peripheral activity. You're right, okay? But does periphery have anything to do with accommodation? Okay, so let's think about it. We have a magnocellular pathway, we have a parvocellular pathway, okay? So for me, look hard, look soft is all about teaching them that sometimes less is more, okay? So I'm gonna grab something real quick. So I like just using a heart chart, okay? I just use a heart chart and I'll hold that. Hopefully you can see that. And the way that I do, this is an interactive or introductory activity. It doesn't require any other equipment than a near detailed target of any sort. Okay, so I'll put this up on the wall and then have them get pretty close to it, somewhere around 12 to 16 inches away from this. And I have them look right into the center, so where they can just look at that TOSX on this one, and really patch one eye. We use the patch, clear patch, and have them look at it. And then what I'll have them do is, and you probably all have done this activity, is I ask them, I want you to look hard, okay? And I'll tell them what I mean by that is I want you to pretend that you have a laser beam in that eye. And I want you to just look hard, and just focus, because it's an accommodation activity. So I'll use that term focus because I want them to get it clear. And I want you to look at it. And sometimes I'll joke with them. I'll say, do you have any brothers or sisters? And if they say yes, I'll say, okay, now I want you to look at these letters like it is your brother or sister that took your favorite toy and you're just gonna laser beam them, okay? And so they'll look hard, hard. And then I'll ask, now I want you to look soft, like butterflies and sheep and cotton candy, and really, and use audible snaps and have them open up their periphery to where they feel the notice the difference, okay? So then as they stare hard, they identify how they physically feel and then identify any changes that they notice, okay? So if they're focusing hard on the center of the target, they're going more central. That means they should be blocking out more of their magnocellular or their periphery. So these ones over here should go blurrier, okay? Then I'll say, now look soft and note, how do you feel and how does this feel out here? And most of the time what they'll say is they say, well, it feels easier and these ones are easier to see or identify. And so that's when we can tell them and present to them idea that sometimes less is more. So just because we're looking at one item and we're focusing on that item doesn't mean we don't keep our periphery open and we don't create a soft look to utilize both the Magno and the parvocellular systems at the same time, okay? So how the patient looks has an effect on both the target and the patient. So if that patient is used to looking hard at everything and trying to focus hard, well, all day in school they're doing that, it's getting harder and harder for them. So in this central and peripheral system, I have some slides here. We're going to go through it relatively quickly because we've covered this in other webinars also, but it just helps to remind us that periphery isn't just an ocular motor or a binocular thing that we need. It is periphery. Magnocellular is also part of accommodation, but then parvocellular, it comes even more as a part of accommodation. And so we'll look at that. So the foundations, there's two pathways that carry information into the brain. Okay, they follow the ventricle and dorsal systems. So you have the parvocellular system, which is the focal, which is going to be the what it is. Then you have the magno, which is going to be the peripheral, which is where it is. Okay, so both of these are what are called parallel processing. So they're happening simultaneously, but they're sending different types of information that the brain is using to create a total network or perception that's going on. They're not isolated, nor do they happen one and then the other, but they're always going on together, okay? And optimally, what we would want to have is that they both reinforce, they both help each other. The magnocellular, knowing where things are in space, helps the parvocellular to know where to look and then where to focus and to identify what it is. And when they're working together, okay, then they're going to bring about the behavioral response that we want, okay, that we're looking for. Okay, now the magnocellular, this is mainly the peripheral. It's orientation, balance, posture, okay? It's going to help take care of that tripod. If we're trying to keep the cameras lined and still so that we can get a clear picture, then the periphery is going to help to get that balance where we need. It keeps the word level. It also tells us if we're moving or if the object is moving. Are we going to have a pursuit activity to do this? All these things are involved, okay? Using the information from the magnocellular pathway along with information from other areas of the brain, that's how we get our 3D construct of space, okay? It is where it's going to regulate how we guide our movements, how we get all the signals that we need, time, distance, all these things, and speed of that object, whether it's going away from us or coming towards us. So if you think about a baseball player, he's looking at the ball, he's wanting to make that ball clear, but it takes that magnocellular system of where that ball is in space as it's coming towards him to coordinate the effort of convergence and accommodation to get that ball to be clear. Then vice versa, the parvocellular pathway, it's going to process the visual information about shape, size, color, clarity, contrast, detail, okay? It is the what, okay? It's very small. The very last slide that we have, kind of interesting. It'll kind of tie everything together. But that what we want is, in order to have good accommodation, then it has to have whatever the object that we're trying to see has to be on the fovea. If it's off fovea, then we don't have a high concentration of the cells necessary to get a clear image and picture. So we need that magnocellular system to tell us where it is so that we can align the parvocellular system to get that clear picture that we're wanting. An imbalance between these two. So if you have somebody that is dominant parvo, they're very central, they're very exclusion of their periphery. Usually they're very highly sensitive, okay? They'll be sensitive to lights, they're sensitive to motion, they're sensitive to all these different things, and they're really off with their depth perception because they're not utilizing that magno. If they have too much magno, which that's me, okay? I have to sometimes pull myself in, then they're unable to see things clearly because they have poor fixation, because they're willing to just see stuff in their periphery more than actually look at it. Very poor attention spans, easily distracted, squirrels, you know, all the different things that are going on. And then they have a difficulty with like information-based tasks that require them to really look and to really understand and see stuff clearly. A clue that there's an imbalance, okay? So if you have somebody that has a reduction in depth perception or has very poor spatial tasks, then you probably have somebody that doesn't have good magno, right? If they're having to kind of manually switch between the two systems, right? When they ask them to look at a central target, they ignore their periphery. Or if you're doing peripheral targets, they ignore the central, then there's probably a balance that is not something that's not keeping in balance. So I won't go through all this, but the main thing that I would like to look at is, when in doubt, use the magno. And why I say that is because it's kind of what developed first, okay? And the magnocellular system will begin to help you to align so that you can begin to utilize the parvocellular system, okay? So the magnocellular system, by getting them to open the periphery, see things that are in space, know what is around what the object of regard that you're wanting to look at, is going to help to reduce strain, okay? Second, it's going to improve depth perception, which, remember, we're accommodating on that z-axis. So the better we understand where that is in space on that z-axis, utilizing magno and depth perception, it's going to be easier for it to accommodate. Motor skills are going to improve if you're asking them to do a task and being able to localize. And it's always going to get their eye movements just a little bit better. So if you're doing saccades with accommodation, they need to have more magno, okay? So opening up that periphery helps. Whoa, who knew all these different things could be done through the Magno cellular system, and through the Parvo cellular system. And so give you just a moment to look at that. But the main thing, since we're dealing with accommodation, kind of pay attention to that Parvo cellular, okay? It's our object vision, identifying what things are. It's primarily macular, okay? So we want right on that macula. And then there's a little bit off of the macula, the Parvo macula, and that's gonna be a little bit blurrier, but it's gonna hold everything in. But detailed recognition, symbols, objects, faces, locations, processing letters, words, objects of recognition, okay? Detailed memory, okay? And then the biggest one is 70 to 90% of our memory of facts occur through this system. So it's really important for our readers that as they're reading, if they're gonna have good comprehension and then good recall, that the Parvo cellular system is working and that they're gathering that information correctly. So we're almost out of time, but let's do this. I do want to get to at least one activity this week, and that is just the bullseye, okay? I always think that we're going to get farther along and then I talk too much, so I'm sorry about that. So when you're doing the bullseye, of course, you're going to need a patch. And I do like the clear patch because it allows me to see the eye that's behind it. They still have good periphery, but I take out the central of the eye. So we're going to use one eye and then we'll just flip it over and use the other. But basically, they're just going to put their patch on, and whatever patch that you use and whatever works in your clinic, that's fine. But as they have that patch on, okay, then you can use a bullseye, and I'll hold this up here. You have just a regular bullseye, or sometimes I'll use a clear chart, a near far clear chart. And the reason I'll do that is twofold. One, sometimes these lines, it's harder for them to recognize when it's blurry and when it's actually solidly clear, okay? But if I go to the letters, okay, those letters, it's really easy for them to identify when they're looking through, if they're blurry, or if they're looking at when they're actually clear, because they have to have them clear enough that they can read. The other thing, and this is not faulting kids, most children, they just want to tell us what we want to hear, okay? They want to please us. And so by having the letters, if I think that there might not be telling me just exactly the whole truth and nothing but the truth, I can have them spell a line, okay? I can have them say the letters, and so that way I know that they're clear, okay? So whether you're using the bullseye or you're using the letters, basically you're going to get an object, and sometimes we'll use a clock that's on a wall, or we'll put a heart chart up on a wall. And basically what they're going to do, again, having a patch, I won't put the patch back on, but they're going to look through the target, okay, to the object of regard, okay? And when they look through, because we can only focus on one place on the z-axis, if they've totally relaxed their accommodation out to where they're out to the object of regard, then that means that this should be all nice and blurry, okay? Then as I ask them to pull it in, now it's want to be very careful. If you have somebody that doesn't know how to use their accommodative system, and you put this 4 inches or just this far from their eye, they're having to accommodate a lot to make this clear, okay? So for me, do I want to get them to that point? Yes. But is that where I want to start out with? No. So I want them at harm and distance, okay? So a little bit of crook in the elbow, right out here where normal reading is, and then they look through the target to one that's near, and they tell me it's clear. Then when I want it in, I have them bring it in, and as they bring that eye in, they make this clear, they tell me when it's clear. And we start going through, how did it feel? Which one felt flexed? Which one felt relaxed? Where in space did you feel like you're looking through? And we're working through those different spots. Or if we're using the letters, you know, which one was easier? Was it easier to see that which was far, or was it easier to look at that which is close? Because some of them that are so used to accommodating, maybe that's easier for them than doing the relaxation. So we're trying to find out what is easier for them. So after a while, it's really boring just to look at a clock. So what I do is I have my little animal friends, okay? So I have all these animals that are cut out, and I hide them all over the therapy room. I just take them and I lay them out and I put them in different places, and I'll put some maybe on a wall or some on a desk, and I'll put them all out there. And then, especially for small kids, we then go on an accommodative bullseye safari, okay? And so this gives me an ocular motor task because they have to find the animal, okay? So it's spatial orientation. They're trying to find where in space and around the room where everything is, and they're kind of making a map of the therapy room and the sames and differences. You've got figure ground, you've got all this stuff that is going on. And then once they find an animal, in order to capture the animal, okay, they have to either the bullseye or the near chart, they have to relax their accommodation through, make it clear. They have to flex their accommodation, make the letters clear. Relax their accommodation, make the animal clear. And once they've done that, they can go pick up the animal. And then I have another chart that has all the animals on it. And they come up there and they stick the animal. We have a little tape on the back side of it. They stick the animal to it. So they kind of know what animals they're looking for. And it's just a little bit more of a fun way to do an accommodative bullseye going back and forth. For older kids, anybody that has an SVI, if you take your SVI and just go to the word saccades, and you can set it up there. I set it up for like the 5th grade, and I put like 20 words out there, okay? And I make them as, you know, a pretty good size font, but I have the patient step back, you know, about 10 feet. And then now we do a near far. And so they're going to do the same thing, but they're going to capture the words. And so if the word up there is the word water, they would look through and they would make sure that water is clear. And then when it's clear, they would spell it W-A-T-E-R. Then I would have them come in and clear the near chart or the near bullseye. They tell me it's clear. Then they relax out and they say that the word water is clear. They spell it backwards, R-E-T-A-W. And then they use it in a sentence. So again, I'm utilizing, it's an ocular motor activity because they're doing saccadic activity. I'm utilizing periphery because they're trying to find it within that board. And then they're using their accommodation to relax, to flex. And then I always end with a relax at the end of it. And then they're also doing spelling with a cognitive load. And then I ask them to give me a sentence with that word in it. So I went to the store and bought it. Water. Okay, so then I'm adding a little bit of a cognitive to it. So this gets them used to using their accommodation system when they're looking for stuff. They found something, they know where it is. Now they are identifying what it is, and then they're still using that to now make a sentence and identify and using it for a cognitive load. So that's kind of the first activity. So unfortunately, we're about done as our time here. I do want to open it up for questions if anybody has questions, but next time that we do this, we'll just keep going through activities. I have more activities in here, and then we'll go. I will give you this little slide so that you can see. This is what I was talking about when we think about vision. Right here in the center is clear. So that's why we have to have that periphery, is to help for motor alignment to get the camera where we want it. And then as you go off the macula, then you begin, if you get off that fovea, then you begin to see that things get a little bit blurrier and blurrier. Okay, so back to bullseye. Is there anybody that has any questions that they would like to ask? Okay, so Wendy, I like this question. At what age do you stop testing accommodation? If you have an older patient, okay, that has a bifocal, then a lot of times they're going to have difficulty with accommodation, right? Okay, now I actually had a lady that came, she was a doctor. The only reason she came is she wanted to get rid of her reading glasses. She was 53 years of age, and we did so much near far heart chart work. I actually ended up giving her like 3 charts. So she had a far chart, a mid chart, and a near chart. And she worked really hard. She ate healthy and all these different things. And she succeeded. She got rid of her glasses. I haven't. All right. So what I try to do is if I have somebody that's older and they have a bifocal, even if I can get them just to flex a little bit, that's great, because the more flexibility they have, then the slower the progression that they're going to have to add the ad, right? So if they come into us and they're in their 40s and they have a +1 ad, and I can work on them and they kind of feel the difference, well, yeah, they may end up in a +150 and a +2, but it might slow it down. So that's kind of I do it. But if they're frustrated with it and that's not why they came, they're a TBI patient, they're not here, they don't mind wearing bifocals or progressives, then you don't have to do that. But I do want them to know the feeling of flex and relax with accommodation. Good question. Anyone else? Okay, well, I thank everybody that joined us today. I know that you guys have lots going on, and we'll work on the next one. I think the next one, we're gonna do it a couple weeks earlier so that we don't get into the holidays too far, but we'll just continue with accommodation and work on some more activities for that time. All right, thank you very much. Have a good day.